Hello, and welcome to Finding Relief, Exploring Medications and Tools for Managing Pain in DM2. My name is Scarlett Chidgey. I'm Director of Development at Myotonic Dystrophy Foundation, and it is my honor to welcome you to this session today. Just a few things. Today's session will run 1 hour, and there will be time for Q&A after our presenters speak. So it is my honor to present Dr. Laurie Gutmann and Dr. Shashank Dave. Dr. Laurie Gutmann is professor and chair of neurology and co-director of the Neuroscience Institute at Indiana University School of Medicine. She received her MD from West Virginia University, did residency and neuromuscular fellowship at University of Virginia. She has a long-standing clinical and research interest in hereditary neuromuscular disorders. Myotonic dystrophy is a disease that she has a long-standing interest in, including research into the neuromuscular and cognitive components and involvement in developing clinical care guidelines. She and her neuromuscular colleagues continue to care for people with myotonic dystrophy in a comprehensive clinic at Indiana University School of Medicine. She considers education of medical trainees about neuromuscular diseases an important part of her work. Dr. Dave is a double board certified physiatrist and pain management specialist, an associate professor of physical medicine and rehabilitation and neurology at Indiana University School of Medicine. He received his undergraduate degree from Loyola University Chicago and his medical degree from Midwestern University. He completed his residency in physical medicine and rehabilitation at Loyola University Medical Center, serving as chief resident. His clinical interests include musculoskeletal medicine, interventional procedures, and the rehabilitation of neuromuscular disorders. He is also the site director of the Lifestyle Medicine Residency Curriculum at IU School of Medicine in conjunction with the American College of Lifestyle Medicine. Okay, thank you very much.
We're going to go back and forth a little bit. So we'll both stand up here. And as mentioned, we're really interested in hearing your questions at the end. We don't have a lot of slides. And so this is just a general overview. I think this is an important topic for sure and has been very interesting to me over the years. We know that muscle pain is a part of myotonic dystrophy in both types, but in DM2, it can sometimes be the very first symptom, and patients can be seeking answers for why they have muscle pain before they know, for a long time before it's discovered that they have DM2. And the pain can really interfere with daily activities and function. So it's not just muscle weakness that becomes disabling for people with DM2, but also the pain. And it can be a problem just for any kind of activities of daily living. And in combination with the weakness, can make it difficult to do simple things like climbing stairs or just getting up off the ground, getting out of a low couch, things like that. There was a nice study that was done through one of the observational trials that some of you may have participated in, the PRISM 2. And out of that came an interesting finding of what are the common areas of pain for DM2. And you can see why it is often not recognized if people don't already have the diagnosis of DM2, that this is part of a muscular dystrophy, because it's neck pain, shoulder pain, back pain, hip pain. A lot of people get those kind of pain that focus a lot on just the joint itself. And it may be the joint, which we'll talk about later, because of biomechanical problems, right? So you have to change because you have weakness in your shoulders or you have weakness in your hips. You change the way you walk, the way you do things. But it can sometimes not make people think about, oh, this is part of my DM2 diagnosis. So why do people with DM2 get pain? I just talked about it. It's complex. It's not fully understood. We can't say it's this particular part of the genetic problem that causes the pain in DM2. It's most of the time muscle pain, right? People say, oh, you have trigger points, you have this, and they just try to treat it as that, which may be appropriate, which we'll talk about some in a bit. But again, recognizing it as part of an underlying disease can be important. And then there was another study that was done that I found very interesting, because for many years as a neuromuscular specialist, I was taught, no, there's no nerve problem in myotonic dystrophy. It's all muscle and the pain is all myotonia. We know that it's not all myotonia. Myotonia can be painful and can interfere, but that's not the type of pain that we're talking about here. But in this particular study that was done in Germany, they did find that there were changes and in some of the nerves that could cause pain. So sometimes it looks a lot like what you may have heard about small fiber neuropathy. And so that pain can be like that, sometimes a burning pain and not just the muscle pain that is a little bit more common. So what kind of tests can we do? One of the things we want to do is make sure we're not. So I said the pain can be related to the DM2, but it can also be due to other things, right? And so you have the opposite problem. Then people say, oh, your pain is just your DM2. And maybe you have a problem like you need a hip replacement. That's not your DM2. That may be because of the change in the way you walk. It could be because of what you've done your whole life for your work, or so there's lots of other things that can cause pain, and we worry about dismissing something that's fixable and might relieve your pain rather than just saying, okay, this is just part of your disease. So you might get x-rays, you might get MRIs, that kind of approach.
So these are some non-pharmacologic ways to treat pain. So number one, physical therapy. It can't just be any garden variety physical therapist that you go to, though. And it helps if the physical therapist is familiar with DM2. Strength training is key. In our field, we feel strength training exercise can beat just about any disorder. However, you want to make sure that you don't do too much muscle damage. So we talk about these sub-maximal strengthening exercises. So the physical therapist will be able to figure out what your maximum is and then back off about to 70% of what that maximum is, and making sure that you pace yourself during exercise so that you're not sore the next day. If you're sore still the next day, they're probably still overdoing it. And that therapist needs to hear that feedback back to them so that they can modify their exercise prescription. Flexibility is also very key. So, stretching exercises, making sure that each joint is held to a stretch of at least 30 seconds twice a day, that is enough to prevent contracture. So, a contracture is a permanent soft tissue shortening. So, no matter how much you try to stretch your shoulders, your hips, it become permanent at that point. So, you want to make sure to maintain as much flexibility as possible. The other key thing is balance. We need to preserve balance for as long as possible. There are tiny little receptors that are buried deep within some of the tendons and ligaments in the foot and ankle, and also in your low back. And those can be retrained. Those are called proprioceptors. And there's some specific balance exercises that the physical therapist can teach so that those can be honed really. So with physical therapy, there's things called modalities, and those things are done passively to the patient. So the one on the left is aquatic therapy, and it works best because sometimes DM2 cold can exacerbate it. So if it's a warmer water pool that the physical therapist can actually get in with the patient, there are exercises that can be done within the pool. So you want to make sure that at least the pool is a warm water pool. The one in the middle are hydrocollator packs. That's warm heat, moist heat. That has been shown in multiple studies to help relieve pain. You'd think that if you have an acute injury, ice would work better than heat, but it's actually reversed. The evidence shows that heat actually works a little better than ice does. And then this on the right, that's called an ultrasound. So it shouldn't be red. That's why I put that slide in there. It shouldn't be red. So if the physical therapist and your skin gets red like that, tell them to back off because that can lead to superficial burns. Anyway, so ultrasound is a deep heating modality. So it's another form of heat. So it can penetrate to about 8 centimeters. So it could be for very deep pain. So for instance, within the joint.
So there's different pain medication options as well. I'm sure many of you are familiar with them. There's over-the-counter pain medications. Sometimes people do well with things like anti-inflammatories, ibuprofen, any type of anti-inflammatories. Also, even Tylenol can sometimes be helpful for people. But there's also prescription medications and there's topical medications as well. Some of you may be familiar with them. Some of the prescription medications that get used commonly in DM are those that focus on myotonia primarily. But if myotonia isn't really the part of your pain that you're dealing with, other types of medications that can be very helpful are the kinds that help people who have other muscle diseases. There's a whole list of them that include the medicines that have been used for seizures in the past, but we know in different doses or even in the same doses can be very helpful for people with myotonic dystrophy and other muscle diseases who have pain. Things like gabapentin is one that's commonly used. And then there are also some antidepressant medications that may or may not be so great in depression, but they work very well in pain. And so people need to, when you're looking for something to help relieve pain, it's good to keep an open mind. If you go on Google and you look up the drug and it says this is a seizure medication or this is a medication for anxiety or depression, don't go, ugh, the doctor thinks I'm depressed and that's why I have pain. It's because it works in a different way, different modality by blocking some of that pain.
So there's other things. If the pain turns chronic, and the definition of chronic pain is pain lasting for more than 3 months, one of the most effective things is cognitive behavioral therapy. At our center at Indiana University, we started a pain rehabilitation program, PRP program. And one of the things that it revolves around is cognitive behavioral therapy with a patient seen by a pain psychologist. And that's been very powerful. And there's studies that back up its use as well. So a lot of times when pain turns chronic, that leads to a lot of behavioral changes as well. So if the therapist can go through cognitive behavioral therapy, mindfulness, minimizing catastrophic pain catastrophizing, that can also be helpful as well. Acupuncture, there are studies out there looking at acupuncture and pain. The risks with acupuncture are very low. In fact, I get acupuncture as well for some myofascial pain. You could barely feel the needles going in. A lot of times insurance doesn't cover acupuncture. It just depends on the payer, but it's definitely worth trying something like that if the pain, especially if it turns chronic. We're not really sure how acupuncture works. There's the traditional Chinese, and then there's the Western methods, but either way, the studies showed that it's helpful. And tongue in cheek is medicinal marijuana or even other formulations like CBD. There's some studies out there showing that even that's been beneficial. As part of my practice, I do interventional pain management. We try to do everything under the sun before moving toward interventional pain. So those things are injections like hip injections. The middle one shows an ablation where the tiny nerve ending is burned off. And then the thing on the right is a stimulator. So that actually stimulates the nerves and it helps reprogram the way that the nerve is firing and conducting pain information. But again, with these interventional procedures, it may again provide some short-term pain relief. We're looking for something more durable, but we try to uncover everything under the sun before moving into the interventional world. It's key to talk to your pain management provider if you get referred to pain management, because the pain provider may not be familiar with DM2, may not be familiar with some of the other techniques that could be used within DM2 as well. I would try to emphasize functional impact. As a physiatrist, as a physical medicine rehab doctor, our overview is functionality. So there's things that we go after, like back pain, shoulder pain, those things can be disabling, as can DM2. So I'd really try to emphasize the functional impact that the pain has on your day-to-day sorts of activities. It's a good idea to discuss your medical history. Even earlier this week, I saw a patient that had totally forgotten that she had a particular procedure that we normally do, very common procedure, and that's the one that we were recommending. And then as we were digging around deeper in her chart, it was just like, oh, you already had this done. So that we were just like, okay, we need to switch gears and talk about something else. So it's very important to keep a detailed history, especially if you're switching hospital systems and going to another system where they might have a complete set of records. And what I found is a pain diary is very helpful. Tracking patterns is very key to the pain management physician to see exactly what some of the triggers are. And then also see what has been effective treatment before. So for instance, you may have been put on prescription non-steroidal for another medical problem, which helped and you're able to tolerate it. And then you stopped it because that pain got better. And then later on, another type of pain might come up and you can say, oh, actually, I was prescribed meloxicam or some other medication, and that was helpful, and we can restart that for this condition. Do you have anything else, Dr. Gutmann, with that?
No, I think the pain diary is important though, because we often don't think about the pain until we're in the middle of it. And this is a conscious way of saying, what did I do that maybe triggered my pain to get worse? Even if you have chronic pain, knowing like maybe it's worse in the morning, or it's worse in the evening, or it's worse when I have been sitting for a long period of time and my hip flexors are tight and I try to stand up and it hurts, right? That it is really helpful. And if you're seeing somebody who's going to initiate a program for you to try to help control your pain, be it a neurologist, physical medicine and rehab, pain management person, having them know that information in sort of a concise way is really helpful for them to plan what medication might work for you. Because if it's a certain type of pain, it might be one type of medication, or what type of procedure might help you.
Advocating for yourself. So this is really key, is making sure that the provider that you're seeing is hearing you. Because a lot of times they're focused on, I remember I took my mom to a pulmonologist and the whole focus was just on completing the electronic note. And there was, he had his back turned to her and there was no listening that was going on. So it's just, Mom, we need to find someone else to have you listen exactly what's the problem is. Trust your instincts. So if you think something's wrong, don't ignore it. I saw a patient on Wednesday with DM2 that was telling me her story. I'd seen her for several years, but she told me her story that I had a leg pain and weakness on the right, and it simply got blown off for years until she found some of the neurologists at IU. And then me as her physiatrist, she was telling me her story that she felt like something was wrong with it getting blown off by provider after provider. If you feel like something's wrong with your body, don't ignore it. And then lastly, find a provider who you trust. Find a doctor who listens and takes your concerns seriously. If they can't tell you how many times patients will tell me, oh yeah, I saw this doctor, and they just laughed and said, looked at the scan and said, oh, I've seen worse, and then dismissed her. And I was just like, let's take our patients' concerns seriously. So I'm the site director for this thing called lifestyle medicine, which is a branch of preventive medicine. There's 6 pillars of lifestyle medicine. So lifestyle medicine uses an evidence-based approach towards diseases that are mostly chronic, not necessarily with DM2, but other areas. So things like high blood pressure, diabetes, heart disease, that these 6 pillars can help with health, with promoting health. So one of them is nutrition. So nutrition is key, and there's evidence base showing that a diet that's focused around plants, whole plant foods, so whole food plant-based diet has been helpful. Physical activity has been shown to be helpful for preventing a lot of these chronic diseases. Stress management, relationships and social connections, restful sleep, and then avoiding risky substances like tobacco and alcohol. So the story that when I originally got introduced to lifestyle medicine is that, let's say that you're in your living room, you get up, you to go to the kitchen or whatever, and there's a coffee table sitting right there, and you whack your shin on it while going past it, and it'll hurt for a while, and then it'll get better. Now the next day you do the same thing, and you whack your shin, hurts, it gets better. Now, the 5th or 10th time you've done it, now the pain becomes chronic. And then you go to the doctor, and the doctor says, oh, here, take this prescription pain medication, instead of saying, just move the damn coffee table. So a lot of this has to do with these obvious things that we might be doing to our bodies or not doing to our bodies that will produce chronic diseases. So things like high blood pressure, diabetes, heart disease. So the healthier you keep yourself in these other areas, the less impact it'll have on your cardiovascular system and promote a healthier lifestyle. I think the reason that a lot of physicians gravitate towards it is because it's evidence-based. It's not just somebody saying something over and over again. It's actually backed up by science. And we've started it with our residency and a few other residencies within IU, and it's been gaining a lot of popularity. So
I just want to add that this is important because you aren't just someone who has DM2, right? You are someone who also lives in the world and has a lot of other stressors. Right now, we can't fix the DM2, although we are hopeful to see more treatments in the future. We can control other parts of our lives that may be able to help us reduce our pain. So maybe medication isn't the right answer to help reduce your pain. Maybe it's taking care of some of these other things, including things like what we talked about earlier, physical therapy, stretching, etc. So I think that really is all that we had from the slide standpoint. I did want to say one other thing, and that is that we do know that when Shashank was talking about the cognitive behavioral therapy and mindfulness, we do know that there is definitely a central component to pain. And what I mean by that is that our brain is what tells us that we have pain, and the information that comes into the brain can make us more sensitized to that. And so doing things like cognitive behavioral therapy does help with some of that desensitization, helps you lower the level of pain that you have through a central mechanism. It's not just talk therapy. There's nothing wrong with talk therapy either, but it is really focused on trying to change the pattern and response to pain centrally, especially for disorders that are chronic and that we can't really fix completely. Right. Questions?
So you talk about seeing a physical therapist or even a cognitive therapist. It's hard to find people that are familiar with DM2. Is there any kind of resource to find people that are familiar with myotonic dystrophy? I would love to do physical therapy, but it's a matter of finding a therapist that understands.
So sometimes what is helpful is if you can find, especially like a multidisciplinary clinic for myotonic dystrophy, and get a prescription. Those therapists who are in MDA clinics and myotonic dystrophy clinics, they really understand neuromuscular diseases, and they may not be as familiar with DM2, but they will learn quickly and be able to give you an idea. This is what your therapist can do. And our physical therapist will actually call the physical therapist that person is seeing locally and help to educate them. I was just talking to another one of the doctors, Andrea Swenson, who's at Iowa, and some of you may know her. And she says she spends a lot of time doing educational letters to people and therapists about this patient has type 2 myotonic dystrophy. That means XYZ. As we don't see them very frequently, but they may be seeing you or they may be seeing their primary care doctor. These are the things that you need to keep in mind for this particular person. And so those kind of educational opportunities are available to us who see a lot of patients with myotonic dystrophy. And I think especially now with more electronic health records, even though it means we're typing while we're talking to patients sometimes, but we can actually template these things and just put them in there and send them out to the physician over and over again, reminding them, don't forget this patient, I saw this patient today and they have type 2 myotonic dystrophy, and please make sure that you keep an eye on this. And if this happens, please call me, etc.
Most rehabilitation hospitals, they usually have therapists that specialize in neuromuscular disorder as well. And if they don't, they usually know somebody in the community that does specialize in it.
We have trouble finding anybody that's knowledgeable in this. Is there certain questions that we can ask of a therapist, see if maybe they're not familiar, to see if they can be familiar? Or
yeah, sometimes just even if you ask your doctor, you can even cold call them. I've done that before for patients who they find it hard to come to Indianapolis. I'll just make a cold call and just call around the therapists and say, do you have therapists that have seen neuromuscular disorder, seen DM2? It's going that extra mile for the patient and making sure that it's too cumbersome to come drive. And then usually you'll be able to find somebody at least that is familiar with it and knows the treatment principles. And if not, like Dr. Gutmann said, there's education that can happen as well.
Just a couple of quick things. So I get some multiple treatments. I see a medical massage therapist. On occasion, I get acupuncture when I can get to it. And I also see a chiropractor, not the kind that cracks your neck or stuff like that, but he does a little bit of that trigger type thing because I get pinched like in here. And I'm currently seeing, he's a physical therapist because they keep telling me I have a TMJ or something because it's my spinal cranial, those kind of things in here. I get tight and he did a couple procedures. I tried to stop my brain from thinking where that pulling is at, which seemed to help. But What are your recommendations? I know that sometimes when I get my massage, I'm wrecked for a day. It really hurts the next day. It's too much. Do you think I'm over?
That
Like-
it might be a little bit much. It shouldn't hurt the next day.
Okay.
Does it eventually get better
Yeah.
as does it get better than your baseline? Like
It gets a
before you
little
went-
better than baseline.
Okay. Yeah, I would try to shy away from something that hurts the next day. The other treatments sound perfectly fine as long as the chiropractor isn't doing a bunch of high velocity, especially in the cervical spine. And then some of the other treatments like acupuncture, I think those have been helpful. Yeah.
We have some questions from the virtual attendees. First, do you have recommendations if you were to, let's say, interview a potential provider? What questions would you recommend that a community member ask them to see if they may be a good fit to provide appropriate care, or maybe if, they're a provider that you've talked about that would be maybe more willing to learn to be able to provide that adequate care?
I guess my question is, when you say provider, there's lots of
Let's say physical
Providers.
therapist,
physical therapists.
yeah, or rehabilitation doctor, things of that nature.
Yeah. So I guess during the first encounter, I'd definitely ask how much exposure they have had to DM2 in their training, either in their residency or in clinical practice. If they haven't had too much in the way of training, they usually know someone else that does. If they don't, they can always reach out to me or reach out to somebody else that might be more familiar with it. And the same thing with the physical therapist. Physical therapist is usually a tight knit community and they know one another, just like physicians and most other. They usually know somebody who specializes in it. And it'd be a good idea to not assume that they know, just ask questions, advocate for yourself, make sure that they're familiar with it. Because number one rule in medicine, do no harm. So you sometimes can do harm in some cases. You want to make sure that safety is kept top priority and ask the appropriate questions.
Yeah, and the other thing I would say is the care guidelines are not just for the physicians. The care guidelines can be very helpful for the therapist too. So it's an uncommon enough disease that many people, even neurologists, haven't had much exposure to DM2 necessarily during their training. But the fact that they haven't seen somebody, but they might know about neuromuscular diseases and that kind of care. And as long as they're open-minded about trying to learn, none of us stop learning. We all keep trying to learn, and there's more and more to learn all the time about this disorder. So educating someone, doing it in a way that if they say they don't know anything about it, you say, are you willing to look at these care guidelines? This is what I have, and I think the approach might be a little bit different. That also helps you establish a good working relationship with that person. Yeah.
That's great. Thank you. One more question from our virtual attendees. Someone asks, could you please talk about topical pain medications, including hemp cream?
Yeah, I prescribe quite a bit of topical. I guess one of the reasons that it's a little bit more attractive is that hardly any of it actually gets absorbed systemically. Hemp oil in particular can be combined with other pain medications, things like local anesthetics, muscle relaxants. There's things like gabapentin. Those things can be compounded by a specific pharmacy and then sent to the patient. It'd be applied just topically right there. And it's not 100% response, but I'd say it's very close to 65 to 70% pain response, which is pretty good with very minimal side effects. Sometimes insurance covers it, sometimes they don't, but I think it's worth at least a try. And they seem to be safe. And different things can be compounded. Anything can be compounded really into this. Non-steroidals, local anesthetics, muscle relaxants, hemp oil. Hemp oil can be compounded in this too. So that's a great suggestion. There's also over-the-counter things like Voltaren, like diclofenac. Then there's over-the-counter lidocaine. Those things can be. But the compounds I think that I was talking about are a little different than that.
The question I have is about the general topic of this particular session and relating to pain, and also the overall research and drug development that's going on. Where are things in general terms, types of drugs are trying to be developed, and where's the progress, and what's the hope?
Are you talking about pain medication specifically?
Yes, thanks.
I think a lot of the emphasis these days have been on reducing addiction, but also improving efficacy. When a pharmaceutical company approaches the FDA, they're looking at safety and efficacy. There's
efficacy.
efficacy, meaning how it works. Does it work well? Does it work better than what we already have on the market? The latest medication that I read about, got FDA approval, was a non-opioid medication for acute pain meaning it's short-lived. That medication, again, low risk of addiction, good efficacy, it works well, works better than what we have already on the market. So that class of medications is really being pushed rather than the traditional opioid type, narcotic type pain.
Besides the cocktail, what can I take before I go there? The airport.
We'd have to talk separately. What have you tried already? Have you tried, these are all great questions to ask.
Yeah, I think some of it is trial and error, right? And because it just depends on what's causing the pain. Some of it is actually changing the way you go through the airport, which is that's a hard one to swallow, right? You say, okay, I'm not going to walk through the airport. I'm going to get somebody to push me through the airport, or I'm going to use a walker. And I know that's not what anybody wants to do. But on the other hand, if you're so sore by the time you get to wherever you're trying to go, that you can't enjoy whatever you're about to do, it's not worth it.
The question I had was, you had a slideshow up there, and the middle slide you said, I believe, was a heat moist pack. So what was the name of that?
Hydrocollator, HYDROCOLLATOR. Yeah. It's widely available at most therapists.
Taking a step back, I would not be able to live my life the way I live it if I did not use assistive devices. I'm 60 years old with DM2. It's to get around today. As you see me around here, you will see me in a mobility scooter. I don't use a mobility scooter at home, but at home, I'm only walking less than a half a mile a day, probably. When I get here, up and down, around and through, and I never walk through an airport anymore. I bid it, and I finally said they can push me all the way through. I mean, just standing in line for security becomes extremely painful, and standing is one of the worst things I can do. So rely on assistive devices. It can be a big pill to swallow, but I can still live my life with them. So, and I have to take a lot less pain medication, which prevents a lot less complications and works a lot better.
Yeah, that is something that we didn't really talk about a lot, and that is modifications, right? So sometimes you have to develop modifications for what you've been doing, even at work. For if you get a lot of pain after you've been sitting for long periods of time, they can make some modifications at work for you, so that just like we make modifications for other things, we can make modifications that help reduce our pain.
I agree. A lot of times your physical therapist can also sit down with you to come up with a game plan in terms of some of the modifications that could be written. Either they can support it, or your doctor can also write a letter.
Great. Thank you guys for attending. Did you have more questions?
Just a comment, because I know health insurance sometimes has pretty stringent limits on therapy sessions. Something that did years ago was to go and do several sessions with aquatic therapy to work out a program that he could take home, and then go back to the warm pool at the Y and do that ongoing without needing to rely on insurance.
Yeah, absolutely. Whenever I write a prescription for physical therapy, I always at the end put home exercise program, so it doesn't make anybody dependent on the medical system, to kind of have that independence. Great point. Great point.
All right.
Thanks, everyone.